Conference will now be recorded.
Good evening, everyone. Rick Davis here. First of them, it's my usual slot, first Monday of the month. And you are listening to the High Risk Recurrent Advanced Prostate Cancer Group. We've got a fair number of people, mid 40s today, no newbies. So we'll be getting right into some discussions. Um, I didn't make any notes about what was on my mind to talk to you about. I will mention to you, watch out for a recording podcast that I did with a group called Empowered Patient um, earlier in November. It came through for me to listen to, and I hate listening to and watching these things that I make. But as it turned out, this one actually was really pretty good. Though I say it's hard for me to say that, but it actually was good. I might even listen to it a second time, but she was a very good interviewer, and we got into some interesting stuff. And we'll probably have a, we'll probably do another session anyway. It's going to go on the empowered patient website sometime in December, and then we'll push it out. So it's 23 minutes, I think. It's a good listen. It's also good to push it out to people who want to know about AnCan. It's not prostate cancer specific, although I use a couple of prostate cancer examples. But it's good. So with that said, I have to thank our sponsors who are Foundation Medicine, Bayer, maybe Novartis, um, uh, uh, Johnson and Johnson, um, probably no longer Myriad. We're going to have to change all these in a few. Um, Blue Earth. So
Helix still?
and Telix still. Thank you. Yeah. So yeah, Telix will stay. Looks like we're going to lose Myriad, um, and Bayer's gone very silent. I can't raise them at all, so I don't know what's happening, and they've expired in terms of their sponsorship. So I don't know where we're going. Um. Okay. So um, I am going to start. I know a few of you have come in after the cutoff, so we'll probably have time to get to you if you if you have something and you hang around. I'm going to start. I'm going to sort of go in the order that people arrived. Not necessarily they responded, but they arrived. So, Gerry Smith, let's start with you.
Good evening, gentlemen. First, let me just update what's been going on. I'm 13 days into radiation treatment. I'm 30 days into Orgovyx. I had a PSA done today.
Okay.
It went from 0.23 as a month ago, today at 0.02. My testosterone went from over 500 to 12. I've been doing okay on all these treatments. I'm still trying to figure out how to, after having a prostatectomy, how do you fill a bladder and then keep it full while they're doing your radiation treatment? Because I don't have that kind of control anymore. So any insight on how anybody else has dealt with that, that would be really helpful. And other than that, I'm noticing small changes. I don't know if they're all attributed to the Orgovyx and the radiation or just things in life. And I don't know how to determine those. So any insights anybody has? Do those numbers sound okay for somebody who's been on Orgovyx for about a month? What's your thoughts, please?
So I would say, so just remind me again, your PSA was at 0.23 before you started the Orgovyx, and what's it at right now? 0.02, did you say?
Yes.
I think you're doing great on the Orgovyx, especially in 30 days. Doesn't get much better than that. You can give yourself a pat on the back. It's working just like it should. Your testosterone's gone straight down, just exactly as it should have done. And so that's all good. In terms of the Bob Young, put your hand up, please, because questions like that are the reason we have a live forum here, so you can ask that question directly. In terms of what to do, there's probably huge experience here on how to manage your bladder for salvage radiation. I am guessing a couple of the hands that are up are going to address that. And so I'm going to start with Dr. Russ, because I bet he's got something to say on it. And you have to turn on your mic. There you go, Dr. Russ.
Yeah, I did. Well, it's a complicated problem, and I've had a radiation in my bladder, so I know a lot about sort of having a small contracted bladder or a bladder that overreacts. But there are PM&R groups, and basically learning how to do the Kegel maneuver. If you can learn how to do that and contract when you have an urge to urinate, that is a reflex that relaxes the bladder. That helps. So anyway, I'm not an expert in that area, but it's something you might want to ask your doctors about to see if you can get a consult for PM&R, but not just any PM&R, but somebody knows about pelvic anatomy and pelvic physiology.
Okay, after my prostatectomy, my surgeon had me meet with somebody on his staff who kind of gave me lessons on that.
Good.
Okay, now another thing that we really suggest you do is look in your area in Rochester or where exactly you are for a pelvic physical therapist. There are physical therapists who specialize in the pelvic floor physical therapist. And I don't know, Tony Fig, do you know any physical therapists in your area?
Yeah, I went to Limitless Physical Therapy, and the therapist there used ultrasound to determine whether I was doing the exercises properly. And she had me get into different positions, like on my hands and knees or standing up. And I didn't realize I wasn't doing them correctly. So with her help, I was able to regain more control of the bladder. So it's Limitless Physical Therapy, and they're over near Clinton Crossings.
Thank you.
There you go. So there's one, like we like to say to you all the time, you saw it in the reminder, priceless. So Larry Schuler.
You might ask your radiologist if an external penile clamp would be interfere with the radiation treatment, and that would, you can put that on for however long the treatment lasts, and that shouldn't be a problem. What kind of radiation are you getting?
Cynthia, what kind of radiation am I getting?
salvage radiation.
Salvage radiation,
Yeah, yeah. Is it IMRT?
38 rounds.
IMRT,
Yeah. How many sessions are you getting?
38.
38.
IMRT. IMRT, Larry.
Okay, I have
Okay. Jeff, Marchi.
Yeah, I was also going to mention the clamp, but specifically the Wiesner clamp. Amazon sells it. Wiesner. It comes
Okay,
in 3 different size adjustments. It works quite well. It's all plastic and rubber, and I don't think it would probably be a radiation issue. But again, you should check with your doctor. But that I've used it a couple of different ones, and it's really, really convenient.
Okay.
Thanks. Would you put it in the chat window for us, please,
Sure.
Mr. M? Now, Bob Young's got an interesting question here for you.
Yeah, Gerry, I was just wanting to find out because I'm early on in the process. I have a Gleason 4+5, and so I'm trying to get a number of consultations to figure out whether surgery or radiation should be first-line treatment. And I was just wondering how you decided to go with surgery with prostatectomy as the first line of treatment. What was your decision process?
Okay, 2 things. The first was my general practitioner sent me to a surgeon. So I was in that group without knowing anything about what was going on. And I took his advice, and part of his advice was that after surgery, I would be done. There would be no cancer. If the surgery was, good, which he told me at the end it was good. So I thought I was into a one-time deal. Let's go get this cut out and be done. Since then, I've learned a lot more.
Did you get then did you discover further indication of cancer after the prostatectomy from like a PET scan or something, or what?
My PSA was rising and rising and rising. I've had multiple scans, and they've not detected any cancer.
You're a biochemical recurrence.
But because the PSA is rising, they have me on hormone therapy and radiation.
So let me jump in here,
Thanks.
Bob. Interestingly enough, Gerry was also a 4+5.
Yes.
And any urologist, urological oncologist who tells you that with a 4+5, you won't need more treatment should be struck off. Period, paragraph. I mean, there is no way you can tell. You may be lucky and it may not recur, but the likelihood of recurrence with a 4+5 after surgery is exceptionally high, as you well know from running that nomogram.
Mm-hmm.
And if we had gotten to Gerry before he made that decision, we would have sent him back to that surgeon with the nomogram, with other information, and said, where are you getting your information that I won't need additional treatment?
Again, that was lack of knowledge on my part. I did go 4 years after the surgery with no other treatments, and I'm blessed for those 4 years. The other thing that it did is it forced us to look, and I think we're in better doctors' offices today by looking than we would have been had we just stayed where we were. So thank you to the group.
It's our pleasure. I'm so sorry we didn't find you earlier. But
that was my, yeah.
Anyway, okay, Dr. Russ, you had your hand up and you took it down. Anything you want to say to add? You muted, you muted.
Yes. Back to one of it's the problem related to continence and if you go to, as you said, a specialist in pelvic physiologists, they actually, and it's hard to believe this, but they put these sensors on your rear end, and they're able to determine the wavelengths as to whether you actually can do a Kegel maneuver. So that's the way it was when I was in Florida at the University of Florida, and I was in Gainesville. So anyway, it's not just it's an actual measurement of whether you can do the Kegel maneuver. So you really need, as Rick said, a specialist, a pelvic specialist, PM&R. So that's all.
Okay, thank you.
Thank you. All right, we're going to move on. Mark Nicholson, can we hear you now or not?
Yes, I hope so. Can you hear me?
Yes. Fantastic. You solved it. Good job. Great job. Okay. The floor is yours, Mr. Nicholson.
Okay, thanks. I've been on the road for about 10, 12 days, so I'm not as prepared as I wanted to be, but I'll be quick. I've had meetings with Dr. Justin Gregg and Dr. Tran at MD Anderson in Houston, and apparently I have two treatment options, surgery or radiation, and I was just listening to you guys here. Out of these two, if the cancer comes back and my highest Gleason is 4+3 and another potential 4+, well, I guess I was just trying to pull up the thing, but I've got 4+3 with intraductal and cribriform. And out of these two, if the cancer comes back, which treatment option between surgery or radiation has the most effective follow-up treatment options?
Well, I mean, first of all, the intraductal makes this complicated. As you know, and we've sort of pulled this apart for you a couple of times, back in the day, and that wasn't so long ago, maybe a year or so ago, 2 years ago, people felt that if you had intraductal, that you were better off doing surgery first. Now, it's pretty much even up. I have followed up with Ben Nathanson, who's taking a sabbatical from AnCan for a while because he's going through his own treatment. And he even said to me, I probably wouldn't say that anymore. I would say it really doesn't make a difference. We are not of the view that surgery, the radiation precludes any follow-up treatment. There are enough options in terms of follow-up for you to find some way to treat cancer that comes back. So I doubt very much that Dr. Gregg would be the type of doc who says, well, if you do surgery, we can't do anything after that, because there's plenty that can be done. You have really good practitioners in Gregg and in Tran. So I don't think that should be a factor. We don't think that should be a factor any longer in your decision, not even with intraductal. But I am going to throw this one open to Len and to Dr. John and anybody else to see what they would say. Anybody want to come in on and help me out here?
Can I say something?
Go ahead.
And I can't pretend to know much of anything, except that, what about brachytherapy seeds, which emit really heavy radiation in the prostate bed? What do you think of that?
Let me stop you right there. If you were to do brachytherapy, and we're very familiar with brachytherapy, then it's most likely they would do, use high dose rather than low dose, because not many people do low dose anymore. And if they did it, they would be doing it in conjunction with IMRT. It would not be for an introductal man. I can't imagine they would do brachytherapy alone. So it would be part of a radiation treatment. Len, you have your mic on now.
Okay, hold on. I actually didn't know it was on, but all right. Well, I don't know. We've been going back and forth on this, you know, like the question being, what's better, surgery or radiation for crib reform?
For introductal.
For introductal, okay. Yeah, I think you already summed it up, Rick. I don't think there's any choice among those two that is clearly superior to the other. We know that with the, what was it called, large cell crib reform, that was the most aggressive. That I think radiation was the preferred mode, but for just IDC, I'm not sure that there is an established winner, if you will, between those two modes.
Yeah. Mark, you want to follow up?
Sure. Yes. Thank you. Yeah, I did follow up, Rick, as you suggested I do with Dr. Tran and Dr. Greg both, and just asked them again about the IDC and treating it, and said the same thing you just said. It's 6 1/2 dozen. They don't have a ton of data, but what they've seen, it appears to be treated equally both directions. So I'm leaning towards radiation right now because I've got to look into everything some more and meditate on this, but it just looks a little less invasive. And they are doing the Decipher and the Entera testing on my biopsy slides. And my sister asked me about the BRCA1 and the BRCA2 genetic testing, and I'm not sure if that's in the works or not somewhere. I've got to follow up on that. And I don't know how necessary all that is.
Well, it's necessary, and I think we've mentioned it to you before, the PROMISE test. Did you make a note of the PROMISE test in the past?
Yes, I did. I did the PROMISE test. I've got that sent in already.
Okay, well, that's going to tell you that you can tell your sister. That's going to tell you about BRCA. That's what the PROMISE test is going to tell you about. So you're good on that.
Thanks. Okay.
Now, you know, honestly, I think you have to decide which of the two side effects. You know, I'd suggest you run the Memorial Sloan Kettering nomogram to see what the likelihood is of the disease coming back, but it doesn't include introductal. And so that becomes I don't think the nomogram is suitable for men with introductal prostate cancer with IDC-P. Not going to give you a reliable information. It's probably going to be higher than whatever it tells you is going to underestimate.
What is the nomogram? You lost me there. The terminology, I'm not familiar with this.
Okay, again, I think we've talked to you about it before. Dr. John wants to speak in the interim. Either he'll tell you what a nomogram is, or I'll tell you after we're done, and I will put it in the chat window for you. Go ahead, John.
I was wondering whether anybody knew. You mentioned that you were going to get an Artera AI run. I was wondering if that considers introductal or not. Probably not, right? Is it what information feeds into the AI for Artera? Is it just genomic information, or is it clinical information like Gleason scores and pathology?
You know, John, I think you need to talk to Artera. I mean, before you put any weight on that Artera, you need to call them and say, are you factoring in intraductal prostate cancer, Mark? And your doctors need to too. It's not as straightforward, because if they're not factoring it in, it's helpful, but it's not going to tell you the whole picture.
Okay.
So
I did look at a little video. Like I said, I've been out of town, so I had not much time to prepare. I apologize, but I did look at a video on Decipher and Entera, and it's on their webpage. What these are, they're 2-3 minute videos, so not a lot of information. But anyway, I'll go back and revisit that.
And, you know, again, with Decipher too, and John may know because he knows a lot more about Decipher, but I don't know if Decipher factors in IDC. Do you know, John?
They do have calculations. First of all, your Decipher score, I think, is based entirely on genomic information, but they have a number of other predictions that they use, which incorporate clinical information, like Gleason scores and number of cores, things like that. But I do not think it does include whether you have intraductal cancer or not.
Yeah.
At least I never saw it at the top of those good reports.
Right. And I think you've got to call them and you've got to ask them specifically, does it take it into account before relying on those scores? Because if you come back and tell us, oh, well, my Decipher was this or a Terror AI was that, we're going to say to you, well, did you ask them if it factors in IDC? And if you say, well, I didn't ask them, we're going to say, well, it probably underestimates. And if you say how much, we don't know how much. But that's why you've got to be talking to them, because it's their tool, they're the experts on it. And, you know, we see more and more people with IDC. I don't know what the percentage is, but it's something that I think they're going to have to start taking into account.
Okay, I'll follow up with both companies tomorrow and ask them if they factor in IDC.
Yeah, I know. That's really good. Now that nomogram, and I'm almost certain that nomogram won't take it into account, is a free nomogram. It's prepared by Memorial Sloan Kettering. It's based on thousands of procedures, surgical. Well, it depends what nomogram you're looking at. And you want to be looking at the pre-surgical nomogram, the pre-radical prostatectomy, and it's going to tell you how likely it is that you will have recurrence after surgery based on your biopsy, your Gleason score, your age, and I'm forgetting something. How many cores positive you have. I think that's it, but it'll give you, at least it's a decent idea, but again, it's inadequate in your case.
Okay. All right. I'll follow up from Dr. Tran, I guess, on the nomogram, or his nurse rather.
Well, you don't need to follow up on the nomogram. You can fill that out yourself. If you've
okay. I'm not sure what it is. I don't even know what it is. I just heard the word tonight, and I'm just trying to process all this.
Okay, so Mark, it is a predictor of how well you're going to do with surgery. So if you wanted to follow up with anybody, it would be Dr. Greg, and he could help you fill it in, but you should be able to click on that link that's in there, and you should be able to answer all of the questions yourself from your biopsy report. Do you know what stage you are? Did they tell you whether you're a T2, T1C or a T2A or a T2B or a T3? I don't think you're T3.
I've got that information. I can't get my hands on it right now. Like I say, I've been driving since 5:30 this morning. So.
Mark, you don't need it right now, but you will need it when you fill out the nomogram.
Okay, great. Thank you, Rick.
Okay.
One last super quick question, if I may. If not, I'll move on.
Go ahead. Go ahead.
It's a LabCorp test. This is another question my sister asked about. LabCorp test 481220, which tests for hereditary, family, and prostate cancer genes. And there's a whole list of things here.
Okay. That's probably, well, I don't want to say it's probably what Promise will do. Promise only tests for 28 or 30 genes. So there are a lot of not a lot, but there's a whole number of genes that they may not test for, such as HOXB. I don't know if HOXB is in there, and I'm pretty certain HOXB's in the test that your sister is suggesting. So what you've got to do is go back to Dr. Gregg and ask him about that LabCorp test. I'm not familiar with the test. I don't know if anybody else is, and you just have to compare the panel against the panel of genes they're testing for against the Promise panel, which is published, and see if there's anything in there which is not included in Promise, and whether you need to repeat the test. And if you feel you do, you can get either Dr. Tran or Dr. Gregg to do it. Dr. Russell, you have your hand up, and then Dr. John.
Yes, Rick, two things. One, I noted about that nomogram, because I've been on there before for checking my doubling times, but one of the things it asks for your most recent PSA, but they don't even talk about that nomogram for doubling times related to that. But my question is, for somebody who's trying to decide between surgery and radiation therapy, is there a nomogram sort of similar to that gives you some estimate of overall survival and prediction of recurrence?
Not that I know of. Parton, somebody needs to help me out. What does the Parton table tell you? Can anybody remind me? It's so long since I've thought about the Parton table, which is the Hopkins predictor. The UCSF one, and I forget that name, is not as refined. I mean, the best one we know of is the MSKCC one. I don't think the Parton one is that refined either. And anybody have any other input on Parton or the? I forget what the UCSF one is called. Jim's no. Anybody have any input? I guess. But you can check the Parton table, and you can check Steve R. Do you have some input on that from?
Yeah, the Parton tables. The Parton tables tell you whether you'll have metastasis or death from prostate cancer, depending upon how quickly you recur, whether you recur within, I think, 3 months, 9 months, or greater, what your PSA is on recurrence. And then based on that information, it tells you what your survival will be at 5, 10, and 15 years.
So do you have to know
your release rate and your PSA and when you recur?
So do you have to, in order to get a result from that Parton table, do you have to have had recurrence already?
It presumes that, right? It's after a radical prostatectomy. In other words,
Right.
the Parton table is to say, who needs treatment? Some men don't need treatment right away because they have a late recurrence and their doubling time is longer. And so those men may not have to have immediate treatment. And those who recur early with a higher PSA and a higher Gleason need treatment sooner, because the likelihood is if it's untreated, they will get metastasis and die from prostate.
Right. I mean, I think it's good information, but not for
It's
somebody
preoperative. Rick, it's
pre-surgery.
preoperative, not postoperative. It's preoperative criteria that they use, with the PSA and the Gleason score and clinical stage, and they just judge it, before you do the operation, whether or not you're a good candidate. It's very
Yeah,
similar
but
to the nomogram part and
oh,
tables.
so it is. So if it is preoperative,
Yeah.
then yeah, check the Parton tables. Let me
I
put
don't
the
think it's
name in there. It's so long since I've thought about the Parton tables. I'm pretty
They look
rusty,
at
but
PSA, Gleason score stages, and then, whether it's organ confined or not, whether there's extra prostatic extension, whether the seminal vesicles are involved, whether there are any positive, nodes. So even before the surgery.
okay, Dr. John.
I've got the LabCorp website up here. If I could have those test numbers again, I will look it up and compare it to color.
Yeah, put it in the chat window. Just put it in the chat window, please. That's the best way to do that, Mark. Thank you. And thanks, Dr. John. And lastly, Dr. Russ, and then we got to move on.
I'm sorry. It was just for somebody who's, as you recommended, a nomogram, but somebody who's trying to decide between surgery and radiation therapy. There is no nomogram for radiation therapy. That's what I was asking for.
No, there isn't, but you see where you don't necessarily need it. Because if you run the nomogram for surgery, and the nomogram says you've got a 90% likelihood that your disease is going to recur, you can then decide, well, do I want to do the surgery? And then there's a 90% likelihood I'm going to have to follow it up with salvage therapy. That was my situation. Why did I not do surgery? I didn't need a nomogram for the radiation. The nomogram said to me, you've got a 70% chance of success and a 70% chance of failure and a 30% chance of success. And I said, do I want to roll the dice for 30%? And I said, no, I really don't, because if I'm going to have to do surgery, if I'm going to have to do radiation and hormone therapy anyway, do I need the extra set of comorbidities? Go ahead.
I'm going to beat this dead horse in the ground and just mute me for the rest of the day, the evening. So let's take a patient and he's deciding between surgery and radiation. And the overall survival is a certain degree, and the recurrence rate for both of them is, say, 20%, arbitrarily. So why wouldn't that be an important nomogram? And then they could decide which they choose.
Because I believe that Memorial Sloan Kettering nomogram has a specific use. I believe that the Memorial Sloan Kettering nomogram is very helpful for people with high-risk disease. It doesn't work for people with low intermediate disease or people with intermediate, low or intermediate high disease. It works really well for people who are high risk or very high risk, because what it tells you in that case is how successful is surgery going to be, which is what you want to know. So if you're like me and you're 56 and you're thinking, should I do the surgery? I'm inclined to do the surgery. And then it comes back and it says, well, no, you've got a 70% chance of failure with the surgery from our experience. It tells me all I need to know in making the decision. For me, that's how we use it as a tool here on I'm not saying there aren't better tools. I'm not saying that if you could find the nomogram for radiation, it wouldn't be helpful. But we are using this very specifically to point out to people when they're thinking about surgery and they have high-risk disease, how likely is that surgery to be successful? Gerry Smith had 4+5 disease, and his doctor said to him, I'm going to do surgery and it's never going to come back. And he could have run that nomogram and it would have told him, yeah, there's a 80% chance it's going to fail. And I say that just from knowing it's 4+5, because it's going to be somewhere in that region. Now he can still do the surgery, but he's also going to have to do radiation and hormone therapy anyway. So anyway, we've got to move on. We've got to move on. Okay, the chat window stuff is about the nomogram. All right, who's up next? Who's up next is, I think, Bob Young. Yeah, Bob Young. Go ahead, Bob.
Thanks, Rick. I just had a couple of fairly short questions. I'm 4+5 Gleason. I have had my biopsy. I have my PET scan finally at long last at UCLA this coming Friday. And I'm going to see Dr. Kishan, the radiologist, for a consult next week after the PET scan. And I currently have an appointment with Dr. Posadas, medical oncologist at Cedars-Sinai, for a second opinion. I was just curious, in your experience and others' experience, is it better to get the second opinion at a different cancer institution so that you don't worry about doctors wanting to side with their colleagues at, in other words, my first opinion is basically coming from UCLA. So if I go to UCLA for a medical oncologist, will that person be more reluctant to differ with his colleague as opposed to going to Cedars-Sinai, where they would perhaps be not reluctant?
Well, it's a very reasonable question. I think there are two things that you've got to do, which you've done at the same institution, which is see the radiation oncologist and the urologic oncologist. And you've done that, or you will have done that after you've seen Kishan. Now, in terms of deciding whether you're best suited for surgery or you're best suited for radiation, I don't think that it really matters if you seek that opinion in the same institution. So if it were me, as we said to you, I would have gone to Reddick because we know him, we trust him. We know Posadas, but I really only know Posadas through having heard him speak several times. He seems very smart. Do I like Cedars for a treating institution for prostate cancer? Better than UCLA? No. If I wanted to be treated, I wouldn't be treated at Cedars. If I was in that West LA area or LA area, I'd be treated at UCLA. So my answer is I would see Reddick. Do I think you're going to get a better or worse answer from Posadas? I don't know. I just know that I would trust Reddick more than I would trust Posadas based on my experience. Let me open that question up to anybody else.
Yeah, this is John. I had a colleague at work that we often did second opinions for each other when we had disagreements with patients. I don't think that we really felt that we had to agree with the other person, but I think we were much more tactful and diplomatic about the whole thing when we dealt with uh, when we dealt with other doctors in our own institutions. I think that there's something, I think, first of all, I agree with what Rick says. What's most important of all is how good is the doc that you're getting the opinion of, and not where are they from. But I do kind of think that there might be a little bit of protectiveness that doctors might have toward other doctors in their same institution. And you might be able to get around that by going to someone else if you're doing what Rick says and getting the best possible person. In my particular case, my first 2 or 3 opinions all came from the first institution that I worked with. And they all agreed exactly with each other. It wasn't until I went out to Yale, to another institution, an NCCN institution, that I started getting different points of view.
Thanks, Dr. John. Anybody else want to chime in on this one? Okay.
Just one
Bob, you have another question.
Yeah, short question. Do you guys have an opinion about Dr. Mark Schultz in Marina Del Rey and his oncological institution there?
Well, I do. And we've known him a long time. I personally feel you're best off at a center of excellence.
I was just wondering for a second opinion, for instance.
Well, he's not going to recommend surgery. He never recommends surgery, so he's not going to. You're not getting an unbiased opinion from him. If you want somebody who's really going to weigh surgery versus radiation for you, stay away from Schultz, because he's never going to recommend surgery.
That's fair. I've read his book.
Len, you have your hand up.
Yes. You were talking, Rick, about stay away from a doctor who tells you that you can have surgery with Gleason 9 and he can cure it, basically. And I've heard Schultz say in one of his videos that 80% of Gleason 9 prostate cancer is curable. And we know that's nonsense. I don't know where he gets that from. So I would say go somewhere else for a second opinion.
Okay.
I didn't know that one.
That sounds crazy.
Doesn't it? I couldn't believe it when I heard him say that.
Well, thank you.
Next time, if you come across it again, save the reference, please, Len.
Yeah, okay.
All right, we're gonna keep moving right along, and I have Bob Schwartz down for some time tonight. Is that correct, Bob Schwartz?
That's correct, Rick.
Oh my gosh. Is that because you had lunch with Len and Bill Franklin and they inspired you to talk in the group?
No, it's a different reason whatsoever. First of all, let me tell you, I enjoyed the lunch. It was very good to have the company of those guys and be around them and finally meet them face to face and see my Venice Island brother, Len. But to tell you right now, I wanted to say tomorrow's my anniversary. It'll be 1 year that I've been with AnCan. And I want to say that I'm very thankful. First of all, my wife's the one that found you guys. I didn't find you, and I'm happy for it. And I want to say thank you to all the past members, all the current members, all the previous moderators, and all the current moderators, but especially a shout out to Rick and Len and Captain Jim Marshall, who've been beneficial in helping me in individual things. And then and the people on the screen, it'd be Jeff Marchi, Tony Fig, Frank G, and Frank C. Little discussions on it. And other people, whose names I can't get in there, I apologize. But everybody, but especially to those that have given the ultimate sacrifice. And I think they were courageous in when things weren't going right for them, they gave the information out to help other people on there. And I appreciate that the most. And I find that very touching and compassionate. And sometimes I even hear from some moderators, and this one's pointed at you, Rick. Sometimes it can be a little tough. And I think it's tough love because they're tired of seeing things happen to people that they feel they can help. And I really see that in you. And it's really nice to see that drive and that determination when it comes out. And I hope nobody takes it the wrong way. It's never meant to be mean or inhospitable to people. It's meant to say, hey, I don't want to see happen to you what happened to my friend previously. And I really appreciate that. And I want to thank everybody here from the bottom of my heart, because for the first time in a long time, I got hope. I really do. This time last year, I didn't think I'd be there to the end of the year. So thank you very much to all of you. Thank you very much.
Oh my gosh. Well, that's why we love seeing you on here, because we've seen you turn around. We've seen you do the 180 on this, and it's such a pleasure. I will tell you that I think the next person up is RJ Smith, and I gave him your name today because I knew that you would be very forthcoming in supporting him because he's just starting chemo. I didn't even have to ask you. I knew that it would be fine to give him your number.
I'll tell you what, anything you need that I can be of assistance for to any member, past or present or future, no problem whatsoever. Seriously, no problem whatsoever.
And so I will say thank you so much for those words. They mean a lot to us moderators. And I'd like to give the other moderators, starting with Len, a chance to respond, because he's your neighbor.
Do me a favor. Please pass it on to Ben Nathanson too. I do miss him dearly, seriously.
Yeah, we will. Yeah.
Yeah, well, of course, I have found Bob to be extremely grateful for any of the help any of us have provided for him. He's a very sincere, warm-hearted guy, and Bill and I both had a wonderful time at lunch. And I'll echo what Rick said, Bob, and thanks so much for the kind words for AnCan.
And thank you, guys. Thank you. I appreciate it very much.
And Dr. John's making me laugh here because I think you left him off your list.
No, I said all the current moderators too. I said,
all the current. There you go. There you go. There you go.
But I said the ones that provided specific help to me individually versus everybody, but everybody has. And like I said, the ones that aren't here today to share in it, the ones that paid the ultimate price, that going through their trials, they had the courage to share what they were doing to help others. And I think that's a testament to what this whole organization is about. And I thank you very much for creating this organization where people can share.
Thank you. You know, this weekend. This weekend's a very special weekend here in Tubac because we have Luminaria, which is where all the shops put out their lights and at night, and it's very beautiful, and they put out wine and food and goodness knows what. But I will be in Ashland, Oregon, because the celebration for Mark Valens, who I was really fond of, is on Saturday. And I'll be thinking about your words when I'm at that celebration.
Well, if you have a toast of wine, have one for me.
I will. Thank you, thank you. And that's a great segue to RJ. So the other person who I suggested he call isn't on the screen today, but there may be people who volunteer to support him. So RJ, the floor is yours, man.
Okay. So quick update on my treatment is that I finished radiation. So I had the IMRT, and then I had 3 or 4, I think it was 4 different bouts of SBRT. I had a week of the SBRT as kind of like a follow-up boost on the IMRT for the whole pelvic bed. And then I had SBR treatment of a number of different other metastases. All the metastases that showed up on my PSMA PET scan, except for one of them. One of them, the radiation oncologist said, I can't, it was in my rib. And he's like, I can't really treat that because I can't see it on the CT. And then it's kind of a shadow there. So he's like, you should just, cross your fingers, and then maybe it's like a broken rib that you had before, because that will show up on the PSMA. And he said, also, this is systemic treatment that you're getting. And I told him, well, I'm getting chemo. And he was like, good. So that's what I started last week. So I had my first round of docetaxel. That was, I'm going to have 6 rounds of that every 3 weeks, 75 milligrams, the standard treatment plan. And I would say, you know, like one of the things going in, it was just a really long day. And, you know, not so much the side effect from the chemo, but I went in and, you know, they put the IV in so that they could, you know, do the blood draw. And then I had like the education thing. And I had the, you know, the appointment with the doctor. And then I had the pre-chemo. And then I had like 2 hours of the chemo. So like they said, well, you might be here till 5, and we didn't leave till 5:30. So it started at 10:30. It went to 5:30. But afterwards, I felt okay. And then it really kind of hit me Thanksgiving. Like one thing, usually we spend Thanksgiving with my wife's family. There's like a gathering of like 30, 35 people. And I said, not this year. And that's a good thing because it hit me on Thursday. And then Friday was pretty bad too. And it's just the fatigue. And then when I talked to the doctor said, well, okay, I got your blood work. And so I asked about, you know, the new Neulasta, and she said, well, the thing is your white blood cell count, amazingly, after all this radiation, looks really good, but you're quite anemic. So that's where you're actually going to have the problem. And I think it did. And so, you know, I noticed it like, cause I've been trying to exercise. I took Thursday off. That was my Thanksgiving. Is I just didn't have any Thanksgiving dinner. I just kind of like just laid low and just relaxed. And then I've been trying to get on the elliptical every day. One of the things that I like, there's an objective thing. I get on the elliptical and my heart rate goes up and my RPMs go down. And so it's really hard because I like look at those numbers on the elliptical and I'm like, okay, I'm gonna make it to 1,000 calories because that's what I do, you know. And so, and then Thursday I was like, I can't do it. And then Friday I did it, and I felt like I was gonna die like 3 or 4 times. And I was like, I just keep pushing, you know, like in the chat, I forget who it was that put, you know, like if you can run, if you can get that exercise, you can get the cardio along with the weight training. So I've been doing that. And it usually when I was doing the radiation, it made me feel better. I'd say it didn't make me feel better with the chemo, but now that it's Monday, and so it started getting better on Friday, and Saturday was okay. Actually, we cooked a turkey and kind of did a Thanksgiving dinner with a couple friends actually yesterday. So finally got around to doing that. I haven't had nausea, but I've just been really fatigued with the whole thing. And now that I'm on the other side of it, I'm like, okay, I'm just grateful for that having ended. And it's also something to look forward to in a couple weeks. So it's, you know, and it's also the other piece of this. I kind of signed up for it. So I would say like in the whole discussion that, yeah, I didn't want to add to the lengthy discussion on the, you know, surgery versus radiation, but it's just kind of like own it, you know, and just I could kind of with this radiation thing or with both the radiation for all the metastases, and I was going and getting that and every day and having to hold my bladder. And then also, you know, like you have, when you go into the SBRT, like you have to do the whole enema thing. And it's just like, I was like pretty tired of that, especially when I started getting the proctitis. It's like, give yourself an enema when you already have proctitis. I was just kind of like, what did I sign myself up for here? It's, you know, my goal is to just do what I can and then just own it. Like I own the side effects, and I was on the elliptical and I was looking at the numbers and I was just kind of like, is it going to be really hard? And I was just kind of like, this is what I signed up for. You know, I mean, I didn't sign up for cancer, but I did sign up for the treatment and to make the best of
it. RJ, dial it down. There's nothing wrong with dialing it down. The mere fact that you're doing it is huge. There is a guy, we heard this from, what's his name? The guy who runs the integrated cancer clinic in UCSF. I've just lost his name for a second. He's been around for donkey's years. And he told us about, and this was many years ago in a webinar, about a guy who gives chemo to his patients whilst they're on the treadmill because he wants them moving as they're getting their chemo, literally. So you are doing phenomenal. Bob Schwartz, what have you got to say to this gent?
First of all, RJ, congratulations. Let me ask you, are you getting the shot for the white blood count?
I am not getting it. What they said is that they're going to watch the white blood count, and then if it dips, like it's actually up in the kind of the high normal range. They said if it dips and certainly it goes abnormally low, then they'll give me the shot. So that's
okay. All right. As far as the chemo goes, let me tell you right now, don't use anybody else's slide like Rick's saying. Go by what's good for you. You're not going to be able to do what you did before chemo while you're on chemo. You're going to have to take it easy and draw it back a little bit. Otherwise, you're going to be frustrated with yourself. The best thing to do is have a positive attitude, go into each day and say, yes, I am going to exercise and I am going to push it. And I'm not going to let this fatigue overcome me. But the other thing you got to do is have a proper diet too. Diet, you'll find, will do a lot of things for you. And realize this, it's good to set yourself up. Chemo is progressively worse as you get into it. Just so you know in advance, all right? It's going to get worse, all right? But you can handle it. You're a young guy. You're healthy. You get everything on you. Don't give up. But realize this, going in with the right mindset, proper diet, and the right support, which you're getting from this group here, and a family support system is the best thing for you. But don't judge yourself by other people's standards, how they do. Somebody else might do 10 miles. You might only do 5. You might do 1. You might do 2. Do what's good for RJ, not somebody else. Set your own standards.
Thank you. Dr. John. Dr. John, you're muted. You got to unmute and start over.
I'll start all over again.
Yeah.
You know, except for maybe Tony and Steve, you're the only one of us who's not gray or bald. And so I hate to lose your picture off of this screen with that nice blonde hair. But what I was going to say is that it sounds like you're going to be fairly sensitive to the taxane. And there's no magic about doing exactly 6 sessions, exactly 4 weeks apart. It can always be spread out. You don't have to go the whole 6 if you get an excellent response. So don't worry too much if things get rough. The last PSA I have on you is 0.37. Is that still correct?
It's less than 0.03 now.
Thank you. Thank you.
0.03 they consider to be undetectable.
Oh, that's helpful. Yes.
Yeah, thank you. And the other thing too, Rick, you know, your advice with the cold cap, like I brought that up in the education session. They said, do you have any questions? And I said, I want to know about this cold cap thing. And it's like, do you want to do that? And I was like, yes, I want to do that. And she says, oh, you're going to have to pay for that because the insurance is not going to pay for it. And I was like, it's okay. You know, like if I have one option here, I will take this option. And so they hooked me up with that. And also they told me a little bit more about like what happens to your hair follicles. And of course I had the gloves and I had the feet thing. And I was just kind of like, you know, my wife was there and it was like, can you please take these
his socks off because it's like way too cold. It reminded me, like when I was a kid growing up in Michigan, right? And so with the frostbite, right? And I got frostbite multiple times. I got frostbite in my toes. I got it on my hands. And you're a kid, so you kind of bounce back. But I was like, that'd be like the worst thing is to get frostbite while I'm going through chemo. So it was doing the cold cap, and then I felt also like I had, that was the one thing that I signed up for that they let me do, and I was kind of like, I may keep some of my hair, and then they also said you'll get your hair back sooner if you do less damage to your hair follicles. You want to. It might not be the same when it comes back, but I'm kind of like, I do what I can. So thank you.
Well, the interesting thing is because we've seen this happen where people do chemo and they lose their hair and they've had straight hair like you, RJ, and then it comes back curly. And they'll say, oh my gosh, I always wanted curly hair. You've got to go through chemo to get it, but it does happen. And people who have straight hair, curly hair, it comes back straight. So you don't know. Maybe you'll come back as a redhead. Who knows?
There we go.
Anybody? Yes, somebody else has a hand up. Bob Schwartz, you have your hand up again.
Yeah, RJ, one thing also I didn't find out till later. Try to keep ice chips through your mouth. It'll help preserve your taste buds. It really will. So it doesn't be
okay.
Right.
Yeah.
Good. Yeah, and I will say I was worried about actually getting too cold. I would say like my scalp got numb, my hands got numb, and of course my feet got numb, and I was kind of like, well, that reminds me when I was a kid. But I didn't actually get cold. I just got numb. So I was a little bit grateful for that.
And see, mine was the opposite. I was freezing cold. I could do my hands in ice, but I had to take them out to dry them out a little bit and get them warm again and then put them back in. My feet, I couldn't do. I just took my sneakers off and the place was cold enough. Believe me, I was freezing in that place. But I'm allergic to cold. Ask my wife about that. That's why I live in Florida.
I have your problem, Bob. I ran for so many years in very cold weather, and I got too much. I froze my fingers and toes too many times, and now I'm paying for it. So
yeah,
anyway, let's move.
My coldest time was when I was in Great Lakes, Illinois, and I'll never forget that. I froze that winter. Froze.
All right.
He's in Florida, so let's not use it.
So let's see. We're gonna move on unless anybody else has any words of encouragement. And the next person on the list is Gerry M.
Yes. Just wanted to follow up. Might be premature. I've got my follow-up PSP.
Well, hold on a minute, Gerry. You didn't say a word about, not a word about chemo. Don't you have any words of advice before we get into you because you just finished chemo?
Yes, I just finished a couple of weeks ago, Thursday. It's cumulative. The fatigue has kind of built. Used to be that, the 12th, the 13th day, I could get back to doing my regular workout routine, but I haven't. Now at day 18, I've not gotten back to it. So, and I was anticipating it's going to take longer this last cycle, but my oncologist said probably be a couple of months before I begin to feel normal again.
Okay.
And I guess my question is around treatment options that may be available. Having finished the chemo of the triplet therapy and continuing on with ADT, what could or should be options to consider going forward? My oncologist seems to be of the mindset, well, we'll just wait till resistance and then try something else. I'm not sure I'm comfortable with that. Is there possibility of, MDT, debulking, things like that, or is that sort of treatment futile once it's metastasized?
Well, it's a very good question. We do think that if you don't have too many lesions, that debulking makes some sense. But my memory is that you had quite a few. You had 9 Mets.
Right, 3 on bound and 6 nodes.
Yeah.
Would
So
the response? I guess I had a MRI and PSMA after infusion 3, and they were like, the nodes were like 50% regressed. Would the final response of the nodes be a consideration into whether it was worthwhile?
I'm gonna let Len and Dr. John respond to this one, because I tend to favor debulking, but the test suggests that men who had started off with a lot of metastasis don't do as well as men who started off oligo. At the same time, I don't know if it takes into account, or if there's been research on whether the original nodes were distant like bone, or whether they took into account nodal. I mean, it seems to me with 3 more distant and the rest of them there, I mean, yes, I think you could be a candidate for debulking. In terms of metastasis directed therapy, I think we've just got to wait and see what the next PSMA shows and where those are. Your doc is right in saying that we got to wait and see how you respond to this. Right now, Pluvicto is not approved for people who are hormone sensitive. I was mistaken in saying that it was. What I should have said is PSMA addition shows that it makes a difference, but it hasn't been approved at all. So you're not really eligible for Pluvicto now anyway. And I think we've just got to wait and see how you respond and how you clean up from all of this. That's what I would say. I was gonna, before I go to Len, who's got their hand up? Who's got their hand up? Ooh, it's not telling me.
Dr. John, he had his hand up right away.
Dr. John, yes, thank you very much, Dr. John. Well, I'd like to hear from you, and then I'd like to hear from Len. What do you think about debulking, and when? Because we often also see that people wait to debulk until they've really recovered from their chemo. But go ahead, Dr. John.
Well, as far as I know, Rick is right on target here. There is controversy about whether debulking would give you a better outcome. I'm a little bit less on the favor of debulking than Rick is, because the people that do the best with it are people with lower volume disease than you had. So I'm not as favorable on that as Rick is, but like he says, there's really an active discussion about it. As far as the Pluvicto, I mean, what Rick was right about is that it's really starting to look like Pluvicto in the hormone sensitive space is going to give men longer time before recurrence. We're not, as far as I know, we're not there yet. I personally agree with your doc. I would say that you're perfectly fine continuing your hormone treatment as long as your PSA is very low, which it is, right? What's your last PSA?
0.35 after 5 infusions.
0.35.
Started at 90, and if I had
Yeah,
a
you
deep
still, well, actually, you
rapid-
got even, didn't you even get up and, oh yeah, you started at 62, went to 90. I see my notes now. So now
Yeah,
you're
now-
at 0.35. We're kind of thinking it's going to go down even lower.
Yes.
Um,
Is that a good prognosis?
I think so. I think you're good right now, and maybe if your PSA stops falling, that will be a different story.
Okay. So
Len,
about
what do
how-
let's see what Len thinks too, because all these questions are really being debated as we speak.
Yeah, I agree with that last statement you made, John. And so, Gerry, you're finishing up the chemo, but you're still on hormonal therapy, right? For ADT
Yeah.
plus what's the other drug?
Orgovyx and new backup.
Rebecca. Okay. So I kind of think, they'll take you down to undetectable if you stay on those
Okay.
two, for the prescribed time, probably. And I wouldn't even think about debulking the primary until you see what happens with the current therapy you're on. I mean, suppose you do go undetectable. Why would you want to debulk the prostate? If they
Right.
did if PSA started rising and they did a scan and there was something in the prostate, by all means, debulk it. Attack the mothership there. Make sure no more satellites coming off of that. But,
Okay.
that's my opinion.
Okay.
RJ.
Thank you.
RJ, what are your words of wisdom?
Yeah, and I would say, like, a little bit of the feedback that I've gotten is, one thing, don't push it too far. So one thing about the radiation, it's just more on top. But I will say, like, I think the whole idea behind not debulking when you have all these metastases is that, well, the horse is already out of the barn, right? And so you've got all of, this prostate cancer that's in your bloodstream, it's in your lymph system, it's pretty much everywhere in your body. But there's more than one horse in that barn. So, and I mean,
Right.
you're getting the right treatment to, kill the cancer, but not all of the cancer is going to be killed by either the chemo or the AT. So there is another option there, and it's a relatively straightforward one. And I would say the most side effects I had were, the radiation I got in the prostate and the whole pelvic bed, like all of those lymph nodes, like they'll just like shoot radiation at all the lymph nodes. And they're like, well, we'll treat all of this. It's some significant side effects, but then also, like if you have these metastases in your lymph nodes, that's something where they can target that specific area where everywhere else in your body, it's a little bit, the radiation oncologist was kind of like, well, there's actually not a whole lot of harm in treating the metastases, but, you can't treat all of them. And, odds are that there will be more, and so you can't, like, once the horse is out of the barn, you can't. And so it's more of a systemic thing where the chemo that you've already done plus the ADT, that's your best bet. But if you want to put another layer on top, when the time is right, then you can, and like you have to own the side effects, because they're, I mean, I'm doing, the chemo now after the radiation, but I imagine, like both of them together plus the ADT is no walk in the park either. So it's just, yeah.
So yeah, that's a consideration, the side effects and quality of life, going forward. So, okay, appreciate of the
Okay,
feedback.
one last comment on this topic before we move on from Dennis Correa.
Gary, one last thing down the road that you might want to consider, you can talk to your doc, is intermittent therapy, which might improve your quality of life, because you are on the standard right now, latest standard for treatment for what you have here. And it seems to be working, and you should have a lot of confidence it's going to get you down where you need to be, PSA wise, but you know, just how are you feeling and so forth. That's where the intermittent therapy would give you a hand up.
Yeah, I would just say you're not ready for that yet.
No, down the road.
It's there in the future.
That are you speaking of the bipolar
No.
therapy?
No, we're talking about you taking a break from hormone therapy.
Okay. I see.
Down the road.
Okay.
Down the road. You've got to probably, maybe after 18 months to 2 years and see where you are, then you might be in a position to do that. So.
Okay. All right.
But
thank you.
You're doing great. All right, I'm going to keep running along because we've still got 2 more people. And next up on the list is Barbara and Joe. Barbara and Joe, come on in.
Can you hear me?
Yes.
Yeah. Since we talked to you last, 2 different PSA levels have come in. From the Schultz prostate oncology specialists ran in mid-October, ran a test, came back at 0.149, and just recently at Quest Diagnostics, may even be a different kind of test, but PSA came back at a 0.31, and that was on the 19th of November. And so
no, it just came back today, the December 1st.
it was taken. It was taken on the 19th of November, but Barbara is correct that we finally got it today.
Yeah.
So the question, I guess, is basically, is that a rapid rise? Are we over responding? Dr. Kim, a radiation oncologist at Anaheim Kaiser, has suggested the PSMA that I'm requesting we should wait and see until we get to a 0.5. So I thought I would report that because it's new information and it's different from what we told you the first time we came on with you.
Well,
Go
ahead.
One problem that we're facing here, I'll come back to you, Barbara, is that these are at different labs. And there can be a very significant difference. Now, you gave yes, I mean, you should always be tested at the same lab. If you do get tested at different labs, try and get a test from both labs right around the same time so you can synchronize the difference.
Okay.
Very good.
But it's hard to compare the 0.19 to the 0.35 and say, well, it's gone up, whatever it is, 0.16. It's almost doubled in a month or so because they were at different labs and we don't really know what it is.
Okay.
Now, I would say, and since you're at Kaiser, you can do this, I would be getting that PSA every month.
Okay.
And when was the last time before the 0.35 that you got tested at Kaiser?
Kaiser was September, and it came back they don't do the decimals beyond 1/10 decimal point, so it was a 0.1.
Yeah, they do. They do it, but you have to ask them for it.
Oh, okay.
Oh, I have asked them for it. Oh,
no,
really?
then you have to push them.
Okay.
They will do it. Do we have any Kaiser people here? Oh, Jim Marshall and Jim Marshall and Jeff Marchi, who's in Northern California. Jeff Marchi, how many decimal places do you get your PSA to?
I've been offered it, but I decided not to do that. It would take an
Right.
extra couple of days to get the results, and I just don't want to sweat the small differences.
Now, so that makes a lot of sense for somebody like Jeff Marchi. It really does. And we say when you're down the road, you know, don't worry about it. But when you're looking at how it's growing and it's starting to move, yeah, you need it to 2 or 3 places. So they may be able to go back and tell you. I mean, that 0.35 was from who ordered the 0.35 test? Was it Kaiser or somebody
No,
else?
Well, no. It was to be clear. Dr. Schultz gave me the prescription to take the Quest, right, and that came up at a 0.31.
0.31. And that 0.19, where was that? Where was that?
That was in his office, at Schultz's office.
Yeah, so
and it was 0.149.
149. So we don't really. Yeah, the trouble is we don't really know where he got that processed. So yeah, you've got to be consistent. So when was that 0.31, Joe? When was it taken? Did you say November
19th.
Yeah, well, you know, I'd get another one. I get another one around December 19th, and I'd be watching it. As far as the PSMA, you know, if you're past 0.31, you should get a result. But you're dealing with Kaiser again, you know, and they don't want to give you too many of these. And I think that most doctors, GU medical oncologists that we would refer you to would do a PSMA test at 0.31. Maybe not all, but I think a lot of them would. So I don't know what to say. Who's got their hand up? And then I'll come to Barbara. Jim Marshall and Dan S. Go ahead, Jim Marshall, and then Dan S.
Okay. The thing I do for the last 8+ years is the PSA test essentially every month. Okay. And I found that if 2 days before I stop my activities, in other words, I don't walk, I don't jump on a bicycle, I don't do any of that stuff, and I rest, because provided I don't, it can and we artificially jump the number, especially if it's on the low side. And in fact, I found out today that I went from 0.22 down to 1.0. And I think at the 0.221, I was exercising a bit a day before the test, and I drove it higher. So as I said, I try to do the same thing, exactly the same every month. I always get it first thing in the morning. I don't eat. I don't eat breakfast, and I go first thing in the morning, 8 o'clock, show up there, get the blood test, come back home and chow down.
Okay. I mean, I don't know that it does. I don't know if it makes a difference or not, but I would say you need to be consistent. You just need to be consistent.
Right.
Now, how many decimal places do you get it to? Because you're a Kaiser patient.
2.
So
I find
Jim
2 is fine.
Now, Jim's a Kaiser patient, but in Virginia, so it's different now. And Dan's a Kaiser patient, Dan S, and he has his hand up, and he's in Virginia too. Go ahead, Dan S.
Yeah, ditto to everything Jim just said. Take it the first thing in the morning, 8 o'clock, without breakfast. I do the same thing, and it's 2 digits. It's been consistent for the last 9 months at 0.01. just my circumstances, but be consistent. That's the best advice you're going to get without exercise.
Okay.
Okay. Yeah, I did exercise that day, so.
Okay, Barbara, you have a question.
Well, it seems to me, I mean, and some of this is theoretical because we're in recurrence, but we're just getting started with recurrence with 4+3 and some morbidities in there. So he's gone several months with virtually no rise in his PSA, and then to have this space of 3 weeks to actually have the PSA double, doesn't that I mean, say it stays that way or continues to rise, what does that tell you is happening?
Well, what it tells us is the first thing is, as we said, you've got to get it from the same lab.
Okay.
So we cannot say, well, look, this is what it is, because there were different labs and there can be variants in the different labs. So we can't be assuming that it's doubled. It may have done, but we don't know. We don't have good data to now. If it is moving quickly, then something is going to show up on the PSMA scan. So he needs that PSMA scan. And then we're going to decide how best to treat it. And, there's a school of thought now that maybe the best thing to do is this an MTD type of treatment, even without hormone therapy, that can work. There's a trial that was just done with very successful results that we reported in the reminder last week, where Pluvicto was used for 2 sessions, and then they did some sort of MTD, MDT, metastasis-directed therapy, and it held for 17, 18 months before they needed to start hormone therapy. So we don't know, but that's not approved right now. So we can't get ahead of ourselves. First of all, we got to know where this is coming from. But there's a lot of people that will play whack-a-mole at this point in time.
You mean whack-a-mole with using SABR, using SBRT? Is that what you mean?
Using SBRT, yeah.
Because his oncologist has actually already suggested, now he's already had radiation to the prostate bed, and there was seminal vesicle involvement. So that's what he had initially, and we had no recurrence for 7 years. So this is now just starting up after 7 years with no treatment.
Again, maybe we've got to see where it is, and we've got to see if, God forbid, he comes back and he's got 10 metastases, then it's a whole different ball game.
Right.
If he's got one little metastasis on a lymph node and that's what's causing the problem, then it's another ball game. So we can let our mind drive us crazy on this stuff, but we don't have good information.
Can I just ask if Kaiser, because the radiation oncologist doesn't want to do anything until 0.5. And who is the other gentleman who uses Mark Schultz? Because Mark Schultz wants to do it at 0.2. We see Mark Schultz also. I'd love to talk to the other person who uses Dr. Schultz.
0.2 is pretty much where we've landed after several years with PSMA. And there are papers, and we can provide you with papers. But if they don't want to do it till 0.5, then you're going to have to challenge them and appeal it and finish up going up pretty quickly to Sacramento to the managed care group. And the managed care group is going to say to them, yeah, you got to do it. We'll give you the evidence. There is evidence out there. I'm trying to think who can anybody help me? Who is it that wrote that paper? Was it Antanaraki? No, it wasn't Antanaraki. Somebody wrote that paper on don't wait beyond. Oh, it was D'Amico.
Oh, I've seen.
Okay, D'Amico wrote a paper on don't wait.
Right.
What
right.
if we?
And we're ready to pay on our own
What?
for a PSMA.
But we're also ready to pay for.
I would show them the D'Amico paper.
D'Amico.
I would show them. We can send you the. I'll send you the D'Amico paper, but show them the D'Amico paper, which clearly says you shouldn't be waiting. But
Now,
you're
that's
dealing
not
with
for-
Kaiser.
Is this considered salvage, or what is this considered when you have this secondary radiation in the pelvic bed or wherever? What is the term for that?
Well, we don't know the extent. It's not salvage. He had salvage. What we're talking now would be some sort of metastasis directed therapy.
Okay, that's what it's called. All right, all right. Has anybody paid for a PSMA themselves? I actually do know somebody who did that.
I'd hate to see it. I'd hate to see you pay all that money when you probably will win this fight. It'll be thousands of dollars.
It's about 10 grand, I think. Don't you think?
No, it's less than that. It shouldn't be more than about 3 or 4 grand. It should be about 3 grand cash out of pocket, but you don't need to do it.
Okay.
You're better off. You're better off fighting with them. But again, you're dealing with a doc who's not a genitourinary medical oncologist, so he doesn't know the facts. But this paper, I will say this: the paper, I'm going to put two links for you in the chat window right now.
Thanks.
And I can't remember which is the right one, so I don't have time to look at them whilst I'm online. But this is for salvage therapy as opposed to recurrence after salvage therapy. But I still think it's appropriate. And they may say, "Oh, this isn't the same thing," or "This is later," but it's bullshit. It's Kaiser bullshit.
If say the PSMA doesn't show anything, are you suggesting you do radiation anyway, or do you have to wait to see what's there?
We're not suggesting anything.
Okay.
We're not suggesting anything. What we're suggesting is get a PSMA and then let's try and guide you.
Okay.
We can't give you medical advice. What we can do, and we're happy to do, is try and give you the evidence to get the PSMA scan, which is frankly what you need right now.
Yeah,
right.
exactly.
At a lower reading.
Yeah.
Than they're prepared for.
Yeah.
Right. And one of these two I think one is the paper and one is a report on the paper. But one of the reasons D'Amico said he published this paper was to give ammunition to people who weren't getting their tests quickly enough. Well, we've got a couple of hands up.
Okay.
So Jeff Marchi first, and then Dan.
I was diagnosed 16 years ago, 4+3. I've had surgery and radiation, salvage radiation, and I've been on ADT and an ARPI since my PSA started to rise to 0.2. I go to Kaiser here in San Francisco, but I've got a GU oncologist, the only one at Kaiser. Jim mentioned how he doesn't exercise before getting a PSA test. I exercise every single day. I run a mile twice a day. Wow. I go to the gym 3 times a week. I have always done it every single time. I do get the test early in the morning almost all the time. First, I eat breakfast though first, and I've been undetectable for the last 24 months, less than 0.1. So that's after 4 reoccurrences, and I've had SBRT on my spine on metastasis there. So it's, there's lots of treatments. Are you on ADT or an ARPI now?
Nothing. No.
Yeah,
nothing
that's after the second reoccurrence. Actually, they waited till my PSA started rising again and put me right on Lupron. And that's where I would have been at your point right now. I would be on Lupron, and that would have brought your PSA down to undetectable almost definitely, and stop the cancer from growing. Now, these days, you don't want to just be on an ADT. You also want to be on an ARPI like abiraterone and darolutamide preferably, because otherwise you can become castrate resistant within a couple of years on ADT alone. It took me 2.5 years. I became castrate resistant. Nowadays, they know that an ARPI delays that. So if you get on both, which would darolutamide is really the best. It has the least side
Okay,
effects.
let's not go there. We're not ready to go there, Jeff.
Yeah, but I'm surprised they didn't put him on Lupron.
We're not ready to go there because we don't know what's there. Let's wait and see. We've got to do that. We've got to do that PSMA test first. Then we can tell them what other guys are doing on there. But I don't want to you're going down a rabbit hole we don't need to go down. I've still got to talk to Eric James. So let's move on to somebody else had their hand up. Dan, what's up, Dan?
I really like hearing that.
I was just wondering, are you saying that there's a benefit to get your PSA taken in the morning, an empty stomach, and at the same time every day?
Well, some people think there is, and other people think there's not. So I think that the issue is whenever you get your PSA, try and do it the same time and in the same way. If you don't exercise before you get it and you do it early in the morning, keep doing it that way. If you've exercised first, like Jeff Marchi has, and you've eaten, do it that way. But if you mix it up, that's where you're not going to get consistent results. I've never read anything theoretical that says you have to do it in a certain point of day. Testosterone, yes. When you get your testosterone tested does matter. The time of day does matter.
Oh, it does?
Yes.
When you get your testosterone tested, it does matter. Yes.
And
it went up slightly, but insignificantly to 174.
Yeah. So your testosterone matters because it varies hugely during the day.
Oh. So when should you get it?
Early morning.
Early morning. And you cannot be on ADT and then get a PSMA PET, can you?
Well, you can, but you can be on ADT and get a PSMA PET, but you're putting the cart before the horse.
Yeah,
do the PSMA. This is why I wanted to steer clear of what Jeff was talking to you about, because we don't know yet.
Yeah.
All right. Get the PSMA first, and then we can talk about the right type of treatment.
Okay.
Thank you. Eric James, are you still with us?
Yes. I just had a little anecdote on how quickly hormone therapy can potentially start working. Was 2 weeks ago, I had a blood test scheduled for PSA and testosterone, and it just happened to occur that I was scheduled to start my very first dose of hormone therapy on that same day. So that my testosterone has been pretty consistently right around 185. And that morning 2 weeks ago, I took my first pills of Orgovyx and abiraterone, and 4 hours later, I had blood drawn at the same lab, same time of day I always do. And this time, 4 hours after taking the pills, my testosterone was 81. So it just surprised me it could work that quickly.
I'm going to let Dr. John comment on that one.
It seems too fast for the drug to be in effect. I don't know.
That's what I thought. I didn't think it would have any effect.
Yeah, doesn't it seem? I mean, Orgovyx is certainly fast. I can't imagine that it could be that fast. What was your PSA on that same draw?
It was what it had been for the last month of 1.55. That didn't change.
Well, your next T level will tell the story about whether that was.
I just had that done a couple days ago. 2 weeks after, that dropped down. Testosterone dropped to 1.
Oh, okay. So it is indeed falling. Whether it was what that one particular value was all about, I can't imagine. But
yeah.
But the therapeutic result is obviously happening now that 2 weeks have gone by.
Yep. Okay, that's it.
It is very quick. I mean, it's a little suspicious, I have to say, that it drops in half after 4 hours. I don't know. Has anybody else ever had that situation where they've been tested before and after, very quickly before and after starting ADT? Doesn't help. What, Dr. Russ, come on in and don't forget to unmute.
Yeah, well, maybe Len could answer this better. I mean, I don't know what the half-life of the drug is. We do take it every day, but I mean, I'd be suspicious of that too. Just doesn't sound right.
No, you got to put your.
Oh,
Len, any comment? Any comment, Fratello?
I have a question.
Well, hold on a minute. I know you do. I can see your hand up. Just hold on. Is Len?
Yeah, I was just looking this up, Rick. And I'm not getting. We all know that Orgovyx will drop your T level very quickly, but I'm not getting an actual number of hours, so I can't help. Sorry.
Okay, no help from Lennon. Your voice, your audio is a little rough right now. Barbara, before you, Larry Schuler has his hand up. Go ahead, Larry.
I was wondering, 4 hours since the testosterone peaks at around 7:30 in the morning. What time were those two testosterone tests? And I have my testimony about my testosterone. I started ADT, and I got a 40% drop in 1 week.
Huh.
I always get my my blood drawn around 10 a.m.
Well, how much does testosterone vary throughout the day? Does any doctor have any information on that? The normal variation?
I mean, we've seen it. It can be like from 200, 300 to 700, depending on different times of day. But again, Dr. John, can you talk to that one?
No, but if it was earlier in the group, I'd have a curve all ready to show you, but I can't get it that fast. But it's a significant enough variation that you have to be consistent about your draws.
Go ahead, Barbara.
The gentleman who just saw the first drop, that was the first time you were on ADT, right? You're just starting it for the first time in your life then, right?
Yep, the first day ever.
And your testosterone at the start was 189.
Yeah, right around 185.
Which is a low testosterone. Is anyone concerned about low testosterone and its success with ADT and the second generation drugs?
Well, one thing, I've had low testosterone, and prior to my diagnosis, I was on testosterone replacement therapy for 7 years.
Is that right? Okay. And your doctor didn't say there was never any issue with low testosterone and how it's going to respond to ADT or anything like that?
No, no one's ever said anything regarding that.
Okay. Thank you.
So let's see. We've still got hands up here.
Oh,
Jim Marshall. Jim Marshall.
Yes, on that question, Barbara, I now, after the 5 years, essentially ADT plus a second level, I'm on a treatment holiday for 40 months, and my testicles have given up the ghost. I have a testosterone of about 33, and I'm not on anything, and I'm kind of like on a virtual ADT, and the PSA is down at 0.1. And I'm still functioning, and I'm still out, and I'm still active, except for the heart condition. That's another story. But other than that, hey, life is good.
I'm so glad to hear that.
Yeah.
That
Yeah,
really,
thanks.
it makes me quite relieved. Thank you for that.
Okay, and the testicles, I don't want them to recover, because if they did, I would have to go back on Lupron, and that sucked. Well, it didn't really suck. I tolerated it for the 5 years exercise and gutsed it out, so everything was good. But now everything is better.
Wonderful.
Right.
Wonderful. You made my night.
Thanks for that.
And we have Larry Schuler.
There's been a couple of studies showing, asking the question, does a man's pre-ADT testosterone level indicate his success at suppressing prostate cancer? And higher levels have a different success rate than lower levels starting. And I don't remember which one was better, but that might be of interest, but you really don't have much control over that. So I didn't try to, keep those references.
Dr. Russ.
Yes, I just want to comment on Jim. His testes didn't give up, but his pituitary has.
Okay.
Thank you, Dr. Russ. And I apologize to the testicles. Now I'm blaming their pituitary.
Okay, I think we've gotten around everybody. We've had some great discussions, some back and forth tonight. We had plenty of time because we had no newbies, and this is what happens with no newbies. We really get great discussion. Next week will be Dr. John in the hot seat. Dr. John, will you still be in Canada, or are you home yet?
He just left.
Oh, he just left.
Dr. John has left the building.
Okay, Dr. John's left the building, so we won't know. You'll have to watch. I do know that I'm going to have to write that reminder early this week. So that's it. Thank you, everybody. Great session, and we will see you next week.
Good night, everybody.
Bye.
Good night.
Thank you, Rick.